Hi, this is Ian Carroll from Stanford University's Department of Anesthesiology and Stanford's Neurology Headache Clinic. And I'm here for our live Ask the Experts session with the Spinal CSF Leak Foundation, celebrating Leak Week. And we're here to talk about spinal CSF leaks and intracranial hypotension. We're going to talk for the next 30 to 40 minutes and talk about where we are with the diagnosis and treatment of patients with spinal CSF leaks. I'll spend a couple of minutes just telling people tuning in how things have changed in the last year. Prior to March of this year, about a year ago, we were seeing our CSF leak patients in the Stanford Pain Clinic. That has since been moved over to the Stanford Headache Neurology Clinic, and this has permitted a really multidisciplinary, multi-specialty approach to the problem that has really integrated in the headache neurologist at Stanford. So every other Wednesday at lunch, I sit down and we review our new leak cases as a team with the headache neurologists, including Dr. Rob Cowan, Dr. Meredith Barad, who's here with me today and is going to be helping me with the questions, Dr. Adi Peretz, Nunu Zhang, and Nada Hindea. In addition to having multi-specialty trained headache neurologists, we're also joined by 2 neuroradiologists, and we get to go over each case, go over the imaging together, look at it from a pain management, interventional, and headache neurology approach, and decide if and when epidural blood patch therapy is appropriate, possible alternative diagnoses, and thereby have multiple physicians weigh in on when it is appropriate to treat an ambiguous case within the paradigm of a spinal CSF leak, so that we make sure patients who have a good story for a leak but whose imaging is ambiguous or negative aren't turned away and left with no options. And at the same time, make sure that we're only treating those people who really do have a good story for a spinal fluid leak. At this point, I think we'll probably start taking some of the questions that are coming in. And Meredith, do you have any questions for us? And go ahead and speak up. I'll try and repeat the question after you ask.
Okay. So there have been a couple questions asking about the likelihood of recurring after a patch.
Okay,
and
so
any numbers about that.
there have been some questions about likelihood of recurring after a patch. I will say a couple things about that. There is, what the kind of data you would like to see with this is the kind of data that is used to track patients for instance, recurrence after treatment for something like cancer, what we call survival data or time to endpoint data. There is no data like that in the literature with regard to following people after therapy for spinal fluid leaks, and I think our approach has really been that we expect most people who get better to recur after their first or second patch. Many people go on and appear to have long-term remissions after some number of patches, and we don't know what is the annual rate of failure for those patients. We do have a group of patients who appear to get markedly better for a relatively short period of time, meaning several weeks, after patching at a specific location or at a specific set of locations. And then we think that what we have done is we've identified a place where they're leaking, But because they keep recurring, we're assuming there is some anatomic problem there that prevents them from having a durable cure. Sometimes there's a bone spur there. Sometimes perhaps the dura is worn too thin or attenuated there. And so for those patients, we've been trying to narrow it down to identify a single spot where 2 cc's of fibrin glue reliably and reproducibly causes somebody to have a remission. And if we can identify a spot where that is the case, where someone gets better for 3 or 4 weeks every time we put 2 cc's of fibrin glue in a particular location, that's when we ask our neurosurgeons to intervene whether or not they can specifically image a leak at that location. And we have been finding with our neurosurgeons here that when we do this, the likelihood that they then have a surgical cure is pretty high. So we haven't published any of our data, but we're hitting somewhere in the 60 to 75% range where when we can identify a spot like this and the neurosurgeons go in, there then appears to be a long-term remission. So sometimes they do see a clear dural defect, sometimes they don't, but after they go in and they operate and they put not just the fibrin glue that we use, but Duraseal and other long-term sealants in there, we're seeing patients have long-term benefit. But I have to say that it is more the rule than the exception that patients first get better temporarily before we make them better long-term, either by fibrin glue or repeated blood patches or surgery. Other questions?
Okay. Couple questions about the rebound headache after patch. How long does it last? And does increased pressure after a patch, a rebound headache, mean the patch was effective?
So the question is, just to repeat it, how long do rebound headaches last, and does the new onset of rebound headaches after a patch mean that the patch worked? So the published literature talks mostly about rebound headache as a temporary phenomenon. Our experience here at Stanford has been that probably 90% of the rebound headaches we have seen have gotten progressively better. We have a handful, and I mean, like can count on one hand, number of patients who appear to have significant headaches from rebound that appear to be getting no better after, periods of time now from 6 months to a year. And I'm not sure what to make of them. I know that at Duke, one approach for such patients has been to do some spinal taps and take off some volume. We haven't had as much experience with that here. We've done it for a couple of patients. Surprisingly, with the 2 patients we've done it for most recently, both of them had opening pressures that were measured within the normal range, despite clearly having headaches that were worse when flat and clearly benefiting from diuretics to treat high pressure. And one of them did appear to have some sustained benefit from the spinal tap. The other one did not. So now, does the occurrence of a rebound high pressure headache mean the patch worked? So if you just got a blood patch and somebody put in 20, 30, or 40 cc's of blood around the thecal sac, that blood spreading around the thecal sac will effectively, as you put in more and more blood, constrict the thecal sac and increase the pressure in the thecal sac, generating more pressure all the way up into the skull. And that can cause you to immediately and temporarily have a sensation of pressure in your head and possibly induce high pressure. I don't think of that as the same thing as rebound headache. That's typically transient, doesn't last very long, maybe the rest of the day, maybe a couple hours. And that does not mean that your patch worked. It doesn't mean that you were patched in the right place. It just means that your intrathecal pressure was increased by the application of a patch and the constrictive effect. On the other hand, if somebody puts in 2 cc's of glue in 1 or 2 locations, and 24 hours later you have the new occurrence of a headache that's different from your previous headache, worse when flat, improved when upright, and better when given diuretics, Diamox, Lasix, and Miloride, that suggests a rebound headache. And that does suggest that you've been patched. It starts 24 hours afterwards when you've had the chance to have some spinal fluid build up. Often there's a period between the low pressure and the high pressure headache where things feel somewhat better. The character of the headache is often different. And that does imply that the patch worked. I will also say this about rebound headaches, which is not really spelled out in the literature. We have seen nobody have severe prolonged rebound headache after blood patches. This appears to be a problem of fibrin glue patches. It appears that the fibrin glue seals better and more durably, and that's appropriate when you fail to have benefit from 1 or more epidural blood patches. But the only people we've seen have severe rebound have been the people that we've patched with the fibrin glue, and for some of those people it appears to be durable.
There have been a couple questions asking about the difference symptomatically between high pressure and low pressure, not rebound headache, but...
Okay, so the question is, what are the differences between high pressure and low pressure headaches? Not necessarily high pressure from rebound, but possibly, but mainly what's the difference between high pressure and low pressure? So in terms of clinical symptomatology, both kinds of headaches can cause head pain, both kinds of headaches cause neck pain, both kinds of headaches cause ringing in the ear, can cause vertigo, can cause nausea and vomiting. The headaches associated with high pressure are more often described as being retroorbital or vertex headaches on the top of the head and behind the eyes. There's a phenomenon reported with high pressure headaches that does not appear to be frequent with low pressure headaches, where some patients report pain is elicited by moving their eyes. Typically it's upon looking down, but it can be upon looking laterally as well, and that's a finding that I have not seen in patients with low pressure headaches, but have seen in a number of patients with high pressure headaches. The high pressure headaches are most often described with the quality of pressure. Both low and high pressure headaches appear to be described in terms of a quality, a sensation of pressure. So that's really the same. The location, I said the high pressure headaches tend to be most often vertex or circumferential around the head, whereas classically the low pressure headaches are more occipital, although they can be in other parts as well. But it can be really hard based on just those symptoms to tell if someone has high pressure or low pressure. If someone has high pressure though, they're often waking up at 2 or 3 in the morning when the circadian rhythm of intracranial pressure has their intracranial pressure peaking. We don't see a lot of patients with spinal fluid leaks waking up at 2 or 3 in the morning because they've been flat for several hours. They're often at their best at that point. In addition, when someone with high pressure wakes up in the morning, they feel miserable from having been flat for 8 hours. If they've been flat, and often their high pressure makes it so that they'll sleep up at an angle because they can't tolerate being flat. And then once they stand up and start moving around, they feel better. The patient with the low pressure headache feels great when they first open their eyes and they've been flat for all that time, and then they start feeling worse once they're upright. And our our experience has been that a lot of times people have to actually write down a pain score after being flat for an hour and after being upright for an hour to really appreciate that their posture is making a difference. I've been impressed by the number of people who you ask if posture is making a difference in their headache and they say no, and then you assign them the specific task of giving you their head pain number after an hour upright and an hour flat, and they are in fact different in a way that was not obvious to them or to me beforehand. Other questions? Actually, before that, let me ask my colleague Meredith Barad, an expert in headaches here at Stanford, both trained in neurology, headache medicine, and pain medicine. Any other thoughts that you had that I overlooked in talking about differences in clinical symptomatology between patients with high pressure and low pressure headaches? So she's talking about papilledema, which is a finding on physical exam where there's blurring of the optic disc and some other findings inside the eye that a doctor can look at. The finding of papilledema is something that can give you a good idea that high pressure is happening. Its absence wouldn't weigh strongly in favor of one diagnosis or the other because it can be absent when your pressure is high. But if you see it, it's a good indication that your pressure is high and not low. Next question.
Several people have asked about the relationship between POTS and low pressure headaches.
Okay, so this is one of the, I guess, a hot button tricky issue. What is the difference? What is the difference, or how to distinguish when they should look?
Yeah.
When should an investigation of whether someone who has been diagnosed with POTS, when should they be evaluated for a CSF leak, or perhaps how should these two problems be distinguished? Okay, so this is how. This is the question that perhaps led to a spinal fluid leak program being established at Stanford. So after my own daughter had a spinal fluid leak and was treated, and I had spent a lot of time reading about spinal fluid leaks, there was a section in the New York Times, Be Well section, written by Lisa Sanders, titled Swept Off Her Feet, about a young woman who had a history of scoliosis, temporomandibular joint disorder problems, and had a lumbar fusion despite a young age, had been in a car accident, and then started developing headaches, and then sometime after developing the headaches, started developing dizziness and feeling like she was going to pass out when she stood up. And this Be Well section in the New York Times invited people to write in what they thought was going on, and I wrote in something saying I thought this was a CSF leak. You know, a young woman with a history of scoliosis and temporomandibular joint problems and lumbar fusion probably had some kind of hereditary disorder of connective tissue. Then she has an accident, develops headaches, and starts feeling worse when she stands up. It's a good story for a spinal fluid leak. And the next day, the New York Times published that, in fact, she had POTS, and that the treatment and counseling she received really was focused around helping her cope. And I called up my colleague, Dr. Barad, who's here with me today, and she may remember this phone call. And I said, you know, I talked about the fact that this patient had stigmata of a hereditary disorder of connective tissue, and maybe it was EDS, and wouldn't that steer us more towards a leak? And she was the one who told me for the first time that EDS was also associated with POTS. And that, to me, honestly, when she said that, I can't describe it as anything other than like a bomb going off in my head, because it really bothered me that a genetic disorder of connective tissue should be associated with two separate conditions which are supposedly totally disconnected, both associated with this hereditary disorder of connective tissue, both characterized by neurologic symptoms and headache. One is mysterious, doesn't have good treatment, the pathogenesis of it is poorly understood, and the other one is largely understood, has good treatment for it, and has very specific action that should be prescribed. And I thought, it seems to me a lot to believe that the only two conditions in the world for which you really feel worse when upright should both be associated with Ehlers-Danlos if in fact they are themselves disconnected. At the very minimum, it seemed to me that there was a large opportunity for misdiagnosis, and at a maximum, maybe they are in fact some way related. And so, based on this, we reached out to our 2 POTS clinics at Stanford and said, when you see someone with Ehlers-Danlos and with POTS and with headache, we would like to see them and evaluate them for a leak. And some of the very first patients they sent us actually turned out to have spinal fluid leaks and were fixed with epidural patching. And they, meaning the POTS clinic, really were unaccustomed to seeing their patients come back telling them that they'd come off of their medicines and were doing well and had gone back to work. And that turned a trickle into a stream of referrals, and a stream into a steady stream of referrals, and now a lot of referrals as more and more people have gotten better. And I think if you have a leak in this country and your imaging is negative, that there is a great chance that you will get diagnosed as having POTS. Now, it is poorly documented that that CSF leaks cause tachycardia. I will tell you from personal experience, when we have caused leaks in the pain clinic by, for instance, putting large holes in the dura when we accidentally wet tap someone putting in a spinal cord stimulator or something like that, we have seen people develop really prominent tachycardia. Now, the tachycardia always gets written off as being due to pain, but in the pain clinic, we see tons of patients with acute and chronic pain, and none of them are tachycardic. So I think it's begging for study what percentage of people with new CSF leaks develop tachycardia. It's begging for a study what percentage of people with POTS get better when they get blood patched. And if you believe that an MRI is really 90% sensitive for finding a leak, then none of this makes sense. If you believe, on the other hand, that the underlying sensitivity of an MRI for identifying a CSF leak is low, then it's easy to see how someone with a CSF leak could get diagnosed with POTS. That's what I think.
Maybe you could talk a little bit about the imaging algorithm for diagnosis. Okay,
so the imaging algorithm for diagnosis. The imaging algorithm for diagnosis this year, because in the absence of great data, what you have is a lot of places doing it differently and learning and trying new things. What we do at Stanford is we do an MRI of the brain and full spine because that is the least invasive study. And if you see something on the MRI brain and full spine, you can go after that. You don't need to do a CT myelogram. I would say in 95% of our patients, we then progress to getting a CT myelogram, and the CT myelogram is almost always the study that tells us where we want to patch. It does not tell us if we want to patch. It tells us where we want to patch. And I think that's really what we are largely arriving at Stanford as a mode of treatment is the belief and the practice that at its base, a CSF leak is the combination of a clinical and radiologic diagnosis. We rarely patch someone based solely on history, with the exceptions of someone who has a new orthostatic headache after having a needle in their back or surgery on their back. Sometimes the history is so good that even if the imaging is, even that totally normal imaging will still not dissuade us from patching. But usually it's a combination of the story and the imaging. And so if the story is really good for a leak, with someone feeling better every time they lay flat for more than an hour, and feeling worse every time they're upright after an hour, and they've got tinnitus and they've got nausea, and their imaging doesn't show any contained fluid collection outside of the thecal sac, but it does show that at one level in their spine, they've got this nice calcified disc up against the dura with the calcium rubbing up against the dura. That tells us that we want to patch there. And so we use the CT myelogram most for showing us where we want to patch, not who we want to patch. It's the whole story that tells us who we want to patch, their symptoms, their labs. Is their CSF protein a little bit elevated? Is their serum prolactin a little bit elevated? And their imaging, and what else they failed. One of the big things we want to make sure of is that we're not treating chronic migraines with epidural blood patches. And so it is rare for us to offer a trial of epidural blood patching to someone who hasn't tried basic things for chronic migraine: amitriptyline, topiramate, Botox. These are the basics that someone with a chronic headache has got to try. So the imaging is really the MRI first, which is usually not useful for us, and the CT myelogram for us, which is usually indispensable. Much better at showing us where we want to patch. It tells us if the CSF protein is elevated. It allows us to look at the opening pressure. We found a few people with high pressure through doing those myelograms because the symptoms overlap with low pressure so well sometimes. And then occasionally, especially in people who have an allergy to intravenous contrast, we'll get a radionuclide cisternogram, which is the nuclear medicine study where they inject radioactive tracer into the spinal fluid. That hasn't been helpful in telling us where to patch. It's been helpful in some people in telling us who to patch. Often the most telling finding in that can be early bladder filling with the tracer, which you see in people who are leaking. Doesn't tell you where they're leaking, but it tells you that it's not all in their head. What are the other themes that are popping up there, Meredith?
There are some people that are wondering about some of the mechanisms for causing a leak. So a calcified disc, can that cause a leak? Spinal cysts, maybe you could elaborate on that. Lots of mentions of cysts causing leaks.
So the question is, what are the kinds of findings that can cause a leak? And I will say in this that myself and the whole medical community are largely indebted to Wouter Schivink and Bahram Mokri. Dr. Schivink, the neurosurgeon who spoke for Leak Week earlier today, and his teacher and mentor, Dr. Mokri, really did a lot of pioneering work on what are the things that cause someone to leak. And what's clear is the structures that can cause someone to leak include meningeal diverticula, perineural cysts. We understand from the physics of vascular aneurysms that the wall stress on a sphere full of fluid gets bigger, the bigger that cyst or aneurysm gets. And so perineural cysts that are bigger are going to be more likely to leak than ones that are smaller. And places...
Define that versus an arachnoid cyst. of concern for.
Arachnoid cysts are not things that make us worried about leaks. Those are collections of fluid within the brain that are seen not infrequently in normal individuals. We see them pop up in people we're evaluating for leaks frequently enough that we've had discussions with the neuroradiologist. Should we be paying attention to this? But they're telling us that they see them just as frequently in people who are getting referred for other kinds of reasons, and that really it's not something we need to be worried about. Perineural cysts, on the other hand, especially when they're multiple or when there's one big one, are things that really catch our attention. The ones that are smaller than half a centimeter really don't garner a lot of attention from us. The ones that are a centimeter and larger really have us looking at them pretty suspiciously. Often those are things that get better temporarily with a patch and then require surgery to have something more definitive done for them. A lot of leaks we see are actually from discs pushing on the ventral dura, the front of the bag of fluid, often calcified, but sometimes not. And these discs often look exactly the same as the regular old discs that 1,000 other people are walking around out there without spinal fluid leaks. And so if you have a little disc at T5-6 and you don't have headaches that get worse the longer you're upright, you don't need to do anything at all about that disc. But if you have a disc at T5-6 and it's pushing against the ventral dura and you happen to have headaches that get worse the longer you're upright, somebody should be taking a real hard look at that disc and saying, well, how hard is it to put some blood or glue around that disc and see if it's really causing a problem or not. So we've seen discs do it. We've seen bone spurs on the facet joints, and recently had a case of someone who had been diagnosed as having Chiari with low-lying cerebellar tonsils. She'd had that decompressed, didn't get relief, had it reoperated on, didn't get relief. Imaging of her spine with the MRI was read as normal. CT myelogram showed some calcified bone spurs on the facet joint capsules in her mid-thoracic spine. We had her go see Dr. Shivink to have that operated on, and she is now pain-free after 2 failed Chiari surgeries and a long time. And I will point out an MRI of the brain that was read as negative for a leak, and a CT myelogram that was read as negative. And when we saw those bone spurs, they caught our attention. We put some fibrin glue around them. She had a month of relief. We did that a couple of times, and then had her go for surgery where they could see the leak. So, other things.
There's some concern about a leak being caused by an occipital nerve block. Have you ever seen that, Dr. Carroll?
I have never seen a leak caused by an occipital nerve block. Now, occipital nerve blocks are typically done for pain in the back of the head. Pain in the back of the head is one of the most prominent symptoms of a spinal fluid leak. And so when I hear about someone who has a headache that they're worried is a spinal fluid leak and they're wondering was it caused by an occipital nerve block, I would be more concerned that they had a spinal fluid leak that was originally thought to be occipital neuralgia and then only realized to be postural, or perhaps became more postural in the symptomatology in the time after an occipital nerve block. But I've never seen an occipital nerve block cause a leak, and there should be some when it's done, there should be some substantial distance between the tip of the needle and the thecal sac. In addition, the thecal sac above C6 or C7, the fluid in there is under pressure that is less than atmospheric in a normal individual. The pressure in the spinal fluid up at C2, where they're doing an occipital nerve block, should be significantly less than atmospheric, and so a needle puncture leak at that location you would not expect to lose much fluid, if any fluid, because it should in fact be under negative pressure, less than atmospheric pressure. So I'd be looking for other explanations of the symptomatology and looking lower in the spine for a leak.
Can you get a low pressure headache from dural ectasia in the sacrum?
Can you get a low pressure headache from dural ectasia in the sacrum? So the answer is nobody knows. Dr. Shevink down at Cedars-Sinai has postulated that a cause for orthostatic headaches, headaches that are worse when upright, in patients whose imaging is negative, include that among the causes of that syndrome, let me take a step back. It's recognized that there are a group of people who have orthostatic headaches whose imaging is all negative, and when you look at their spine, what you see is not a clear leak, but a certain subgroup of those people have dilations of the thecal sac, some of which fit the term dural ectasia. And when the thecal sac is in fact big and wide like that, it raises the question of, is it in fact more compliant and distensible? And so when someone stands up, does all of the fluid that should be kind of static in the bag rush down and fill up the bag low down, and thereby mimic the appearance of a spinal fluid leak when in fact there is no leak, but just increased compliance? And if that were the case, then the appropriate treatment would be to remove some of the dura and make the bag narrower and stiffer. And so this is an idea that's been espoused by Dr. Shevink, and a surgery going along with it called a dural reduction surgery. To my knowledge, dural reduction surgery has not been done at Stanford. I have not had a patient who underwent dural reduction surgery, and I do not consider myself an expert in dural reduction surgery. I consider Wouter to be probably the reigning expert in the country on spinal fluid leaks, and I would defer questions of dural compliance to him. I will say this: I know of at least one patient who got appearingly completely better after a dural reduction surgery, so it's doing something, and I don't know exactly what it is. How's that?
If somebody has a repair and they have Ehlers-Danlos, so they have a patch, what should they do to avoid getting further leaks?
So someone has a leak and Ehlers-Danlos, they get a patch, they get better. What do they do to prevent themselves from getting further leaks? This is an interesting question. The answer is there's some common sense things, none of which have any data behind them. The common sense things are: don't go make a living with your spine. You're not allowed to play full contact football. You're not allowed to do full contact taekwondo. You can't help your neighbors move their couch. These things are out for you forever. And I would also argue that things like skiing should be out, because people who ski fall. Even if you're a great skier, you fall. And when you fall and you're moving at 30 miles an hour, there's nothing gentle about that. Now, there is some data emerging from studies of other problems with connective tissue, suggesting that it may be that how a connective tissue disorder manifests across the lifespan may be modulated by inflammation or other medications. And I was recently made aware of a manuscript that has been submitted related to aortic abdominal aneurysms, suggesting that in people with aortic abdominal aneurysms who were treated with a certain kind of medication that has nothing to do with blood pressure, that the size of those aneurysms grew much more slowly, in a way that was postulated that the weakening of the connective tissue in the aneurysm was in fact in some way being modulated or inhibited by this drug that was being given to treat another condition altogether. And I'm being vague only because the manuscript has not yet been published and I don't have permission to talk about it, but it is exciting in the sense that it opens up this idea that maybe some of the medicines that are already in our pharmacopoeia may interact with how the genetic defects and hereditary disorders of connective tissue, how those genetic defects manifest over the course of the lifespan, and may perhaps open up a future where in the future we may say to someone with Ehlers-Danlos, you should be on drug X, not because it's going to help you today, but it's going to reduce the likelihood that you're going to wind up with dural ectasia. It's going to reduce the likelihood that you're going to wind up with large perineural cysts, which I think should kind of be called thecal aneurysms. It's going to reduce the likelihood you're going to develop vascular aneurysms and have other complications of your Ehlers-Danlos. And so I think that's really exciting. And I believe here at Stanford we're going to be doing some animal modeling of this and trying to develop some animal models of this so we can do some high throughput screening of other medications to look and see if we're able to identify medications in the pharmacopoeia that have this kind of effect.
Is it possible to have high pressure and low pressure at the same time?
Is it possible to have high pressure and low pressure at the same time? So the quick answer to that is no, but the more complicated answer to that is yes. Here's what I mean by that. If there is no flow of CSF in the, if there's no flow of CSF, then there are no pressure gradients in the CSF when you're at rest, except those induced by gravity. However, it's been well documented by neurosurgeons in the generation before us that you can in fact obstruct flow either at the foramen magnum or in the cases of significant spinal stenosis lower in the spine, and that can obstruct the flow of CSF. And when CSF flow is obstructed, then you can have areas of high pressure and areas of low pressure. And one of the things that we've been concerned about, and that is not especially well documented, is, let's say someone has a spinal CSF leak, and as part of their spinal CSF leak, their brain is sagging, and they have their cerebellar tonsils down in their foramen magnum, and they've lost the fluid in their prepontine cistern, and their brainstem and cerebellum are occupying much of the volume of the foramen magnum, the hole at the bottom of the skull. That may provoke either continuous or intermittent obstruction of cerebrospinal fluid from the skull down into the spine. So the CSF is made inside the skull, and it normally should be flowing through the ventricular system, escaping and going down into the spine. But if you have a spinal CSF leak and the brain is sagging such that it's now acting like the plug in a bathtub, where it's now preventing the spinal fluid from escaping, you may in fact develop high pressure inside the skull while you're leaking below the skull, and that may maintain that state of kind of disequilibrium. And what would you see in those patients? You would see that that they have some symptoms of intracranial hypertension, such that when they lie down they feel worse because the CSF can't get out of their skull in an unimpeded flow. And sure enough, we know that 10% of patients with spinal CSF leaks report paradoxic headaches. And so the pathophysiology that I just described is a potential explanation for that observation. It is not a proven explanation for that observation, but we know that obstructions of CSF flow can occur, and we know that some patients with leaks have these paradoxic headaches, and we know that if you obstructed CSF flow out of the skull, you would expect to have intracranial hypertension while having intrathecal spinal hypotension, and you would expect to see that kind of phenomenon that is in fact observed in 10% of patients with CSF leaks. And so that's an idea.
Are there any medications that patients could take for low pressure headaches while they're waiting for a leak patch?
Are there medications that patients can take while they're waiting for a patch? We experimented a little bit with giving patients Florinef, and I was not bowled over by it. I was impressed at how hard it is to get patients off of Florinef and how unhappy they are when the Florinef is getting taken away, but I wasn't impressed by them doing so much better when put on the Florinef. And so that didn't seem to be so helpful. And so that did induce in me a kind of therapeutic nihilism about patients with leaks should be patched, and that nothing seems to work in patients who are leaking except a patch. And whenever I get myself in that mind frame, one of my patients will go see my colleague, Dr. Barad, who will give them Botox or nortriptyline or something like that, and then I will seemingly forever be surprised. But it's clear to me that some people with leaks do in fact get better when treated in the paradigm of chronic migraine. And so I've seen a number of patients with leaks whose symptoms are better, not gone, better after getting Botox. I've seen a number of patients whose symptoms are better when they get nortriptyline, not gone, but better, less. It's less horrible. And while I would totally predict that it would not have been the case, I've seen some patients with leaks who are nonetheless better with topiramate, which is a drug that has anti-migrainous activity but also inhibits the production of CSF. But I've had patients who we have fixed with blood patches who have told us before the blood patches, topiramate was helpful. So, it is clear that these medications used for migraine that decrease head pain can decrease some of the head pain in some of the patients with spinal fluid leaks. And even though if you are in the business, like I am, of delivering patches trying to fix and identify the site of people's spinal fluid leaks, that medications and Botox really can be helpful for some of those patients. Would you add anything to that, Meredith?
I think the point is that you can have more than one type of headache.
She's saying that the point is you can have more than one type of headache, and it's a point that's easy to agree with.
What does elevated CSF protein tell you? Why do you look for it, and what does it mean to you?
Elevated CSF protein has been reported to be one of the findings sometimes seen in patients with spinal fluid leaks. It's not clear exactly what percentage of people with spinal fluid leaks have elevated CSF protein. I would say in the people with a good story for a spinal fluid leak, orthostatic headaches, tinnitus, nausea, we have found that to be the most frequent objective indicator that something is not right and it's not just migraine. The elevated CSF protein is there much more frequently than the MRI is read as positive, and much more frequently than the CT myelogram is read as positive, and much more frequently than the serum prolactin is elevated. It is the most frequent objective marker we run into that tells us there's something here, you have to keep digging, and it's worth doing what you need to do to get to the bottom of this. And the theory is that if you have reduced intracranial pressure, the veins distend. We know that happens on imaging, and that there's now a pressure gradient between the veins and the surrounding CSF, and that pressure gradient results in a transudate of fluid from the plasma in the vein across into the spinal fluid, and that it brings protein with it, and that the elevated protein seen in the CSF is a result of the pressure gradient between the veins and the CSF and this transudate of acellular fluid coming into the CSF. And I will tell you that it has on more than one occasion been a deciding factor that made us say, yes, we should go forward with patching someone, or we should persist in patching someone, that we found very helpful.
Let's see, what are you most excited for about future treatment or imaging procedures?
What am I most excited about? Well, it's good that you asked. What am I excited about? I'm excited about two things. We are going to be undertaking some work here at Stanford that I haven't even talked about with Meredith yet. We're going to be investigating whether we can in fact develop a blood test for CSF leaks. We're going to be looking at antigens, proteins in the spinal fluid to see if we can detect those things that should only be in the spinal fluid in the blood. I see two ways of going about that. One is to look for known antigens, things like beta-2 transferrin and alpha-fetoprotein in the serum. The second is to do what I would call an augmented approach, where it's kind of analogous to a radionuclide cysternogram, where we inject something into the spinal fluid and then we sample the blood to see if we can find it. So whether that's a radioactive tracer or some other kind of small molecule, if you put something in the spinal fluid, it shouldn't find its way out of the spinal fluid for a long time. And so we are going to be doing studies like that. And some of those studies may include better defining exactly when you can rely on early bladder filling from, for instance, a radionuclide cysternogram. So if Wouter Schivink was sitting next to me and he heard me extolling the virtues of early bladder filling on a radionuclide cysternogram, he might politely say, but how do you know that the tracer that you're finding in the bladder didn't come from a small leak created by the injection itself? And it's a fair point. And the only answer to that is to do a study where we do a radionuclide cysternogram on a collection of volunteers without leaks or risks for leaks, and we do it the same way and see if any of them have early bladder filling. And the truth is if you see no early bladder filling on a series of 20 volunteers, and you see early bladder filling on 15 of 20 patients with orthostatic headaches, that becomes a very potent set of data for saying, hey, this really is something. And especially if you then repeat it on those patients after you patch them and you show that it goes away. And we've recently, we believe we've secured funding to be able to do that. So that's what I'm excited about, the possibility of a better test. And the truth is if we are successful in coming up with a blood test for spinal fluid leaks, that is going to make the potential misdiagnosis of POTS a non-issue. It's going to make the potential misdiagnosis of chronic migraine a non-issue, the potential misdiagnosis of Chiari a non-issue. It makes a lot of misdiagnosis just go away, because a lot of doctors are tuned into the idea that maybe there's a potential for spinal fluid leak, or spinal fluid leak as part of the differential diagnosis of their condition. And if it was easy enough to just get a blood test that was reliable to tell you if someone had a leak or not, I just think that would be a game changer. It'd be a game changer in POTS clinics, in headaches clinics, in Chiari clinics. I think it would change the way we do this.
There's a question about rebound headaches. What do people typically say they feel like location-wise? And if they don't go away, and what are the treatments? And what if they don't go away for a long period of time? What should a patient be thinking about?
So, we talked a little bit about the symptomatology of rebound headaches before. How do people feel? They feel awful.
Different
They
headache
have
though, right?
they have headache that's typically different than their pre-patch headache. It tends to be more constant. It tends to be, because it hurts so much of the time, they can have trouble telling a postural component, whereas before, when they were leaking, they could feel better when they were flat. And sometimes it can be distressing because they used to be able to at least feel better when they were flat, and now they can't feel better at all. As we said earlier, sometimes it's vertex. It often prevents them from lying down flat at night. Vertex, top of the head. Sometimes it'll be aggravated by them moving their eyes in a certain direction. But other than that, it can be very much like a low-pressure headache. There are some things that are known to be associated with high pressure that we actually query for when we evaluate patients. So tetracycline and doxycycline and minocycline antibiotic exposure clearly does something to the way CSF is resorbed or produced. It predisposes people to high pressure. Steroids predispose people to high pressure, so people who've been exposed to glucocorticoid or steroid medicines for things like asthma or rheumatologic disease are at high risk. People who've taken prescription retinoid medicines for acne, retin A, tretinoin, appear to be at higher risk of getting the high pressure thing. Exogenous estrogen exposure in women seems to be a risk factor. We know that pseudotumor, a condition of high pressure, is more likely to happen in women who are overweight, so weight seems to have something to do with it as well. There's some other medicines like cyclosporin that can be implicated. So if you had a patch and you also happen to have had, prior to your patch, exposure to one of those things, that would be another thing to make you think about high pressure. And then the other question was, what do we do for high pressure? There's divergence of what is done across the country. We have, as I mentioned earlier, not done that much in terms of invasive management of rebound high pressure. We've not done a lot of spinal taps to manage it. We typically introduce Diamox, and if Diamox is not tolerated, either Lasix or amiloride. Lasix, amiloride, and Diamox all appear to reduce intracranial pressure. Diamox and Lasix, while doing that, cause you to spill a lot of sodium and potassium in your urine. Amiloride causes you to retain potassium, and so using a mix of amiloride and one of the other two can make it so that your pressure is controlled without having to take grams and grams of potassium every day, which people hate because it makes them nauseated. We often use amiloride in that circumstance. We used to use a lot of spironolactone for the same purpose, but the truth is amiloride seems to have a lower side effect profile when used long term, and so we've been more reliant on that. When people are using these kinds of diuretics, we tell them not to use any NSAIDs at all, because NSAIDs and diuretics are a good recipe for kidney damage. And I will say, and I think it's important to say, that it is clear that when someone is on diuretics, Diamox alone or a mix of Diamox and Lasix and amiloride, if you start vomiting, you need to stop the diuretics right then and go to the ER and get checked out, because we've seen a number of people who've gotten really dangerously low potassiums very quickly. And as we said in medical school, the kidneys are smarter than we are, and they're doing all kinds of things to protect us as human beings. They're defending our acid-base status, our volume status, our potassium status. And when you start to take away some of the kidney's tools by feeding it diuretics, it can't do its job right. And when that's happening, if you start vomiting, your kidneys are normally protecting you when you're vomiting from becoming alkalotic and hypovolemic and low potassium. And when you take that away from them with diuretics, they can't do that job. And you should have a really low threshold for going in and getting checked out if you start vomiting when you're using those diuretics for high pressure. It's 5 o'clock. Thank you very much, and we look forward to seeing you again next year. This was a lot of fun, and I hope next year someone will ask me questions about, have we made any progress on the things I said we were excited about this year? And hopefully next year we'll be able to tell you that that we have up and running research projects to make those things a reality, and that we're going to be working here at Stanford to make life better for the leakers and make sure that more people out there who are leaking are diagnosed appropriately and brought to treatment. All right, thank you very much.